Good evening, friends.
Yeah, good evening.
Good evening, SEKHAR.
Yeah.
Good evening. Good evening.
Am I audible?
Yeah, you're audible. Very well audible, SEKHAR.
Yes.
Yeah, I think Dr. Prabhakar has not joined. Right? MUNISH Prabhakar is the only man faculty.
Not joined, probably.
Okay.
Shivenda, good evening.
Please. So, good evening, friends. I extend a very warm welcome to all of you on behalf of Scientific Committee Society and Rajasthan Forum of ICP Fellows at this virtual Electrolyte Symposium, which is being organized under the aegis of Indian College of Physicians, which is an academic wing of API. About a fortnight back, we had discussed disorders of sodium imbalance, and today we have planned to discuss potassium imbalance. We all know electrolyte imbalance is a bit complex, but an important clinical problem which is being encountered by every physician in our day-to-day clinical practice. And to have basic understanding of electrolyte imbalance is of paramount importance in patient care. I extend my heartiest welcome to our leaders, our mentor and guide, and one of the senior most leaders of API, Dr. MUNJAL sir. I'm highly grateful to him to accept our request and spare his valuable time to shower his blessings upon us. I'm grateful to my mentor, guide, and leader, Dr. ParEEK sir, past president API, for his most valuable guidance and inputs at every stage of all the scientific deliberations which we do at Rajasthan API. I take the pleasure to welcome our energetic president, Dr. KAMLESH TEWARY. Sir, your gracious presence is a moral booster to us. My heartiest welcome to Dr. RAJESH UPADHYAY, Dean, Indian College of Physicians, a man of versatile leadership qualities and human values. I welcome Dr. SHASHANK JOSHI, past Dean ICP, one of the brightest leader of API and the person of academic excellence of highest caliber. I extend my heartiest welcome to our learned speaker, Dr. SANJAY PANDYA, who is a renowned nephrologist from Rajkot, a master orator and a wonderful human being. I also welcome Dr. NP Singh, member faculty council, a renowned nephrologist from Delhi, Dr. Rajkot, member faculty council. I extend a very warm welcome to our chairpersons, Dr. SEKHAR CHAKRABORTY, Dr. MUNISH Prabhakar, and Dr. DP Singh, all very good friend of mine and member of governing body API. I also welcome Dr. GD RAMCHANDANI and Dr. PRADYUMN Sharma, the pillars of Rajasthan API, who are very active in all the scientific activities which you do at our chapter. And I extend a very warm welcome to all of you, dear friends. Your presence is really paramount to our success of this program.
MATHUR, we cannot hear properly. Can you just increase your volume or voice?
Oh, let me.
आवाज नहीं आ रहा है ठीक से.
Okay.
मैं तो आ रहा है भैया.
Now
को आ रहा है सर, अच्छी तरह आ रहा है.
मैं तो आ
ठीक है, आवाज आ रहा है.
I can hear you very clearly.
even though दादा आपके लेवल पे कुछ प्रॉब्लम है. At the outset, I invite our mentor, Dr. PAREEK sir, for his welcome note.
Thank you, Dr. Girish. Good evening, everybody. It's really a great pleasure and a great honor for me to welcome all of you, and especially our delegates who are attending this webinar today on electrolyte imbalance and especially potassium. I take great pleasure in welcoming most respected Dr. YP MUNJAL, mentor and guide to all of us, and we need his blessings. Dr. KAMLESH TEWARY, President of API, who is a dynamic person and a very good human being. Dr. Rajesh UPADHYAY, Dean ICP, past President of API, and the person who has translated the adversities into the opportunities of learning, dissemination of knowledge. And I think during this time, probably we had a maximum number of webinars and CME programs organized by all these states, almost many of these states. So I must congratulate you for initiating such a important scientific programs all over the state, and I hope our clinicians will be benefited to a great extent. Dr. SHASHANK JOSHI, a genius not only of India but also of international repute, past president and past dean of API, great orator. We have got under the chairmanship of Dr. SEKHAR Chakraborty, API leader from Bengal, member governing body, MUNISH Prabhakar, member governing body, leader of API from Haryana, Dr. DP Singh, member governing body, API leader from Bihar. We have got very renowned panelist, Dr. NP Singh, a nephrologist of great repute. Dr. Rajkot, we know him, he's a great academician. Our own Dr. GIRISH MATHUR, past Vice President and past Vice Dean of API, at present member governing body, and I must congratulate him for being elected as a President-elect of API unanimously. And he's the person behind all organizing all webinars which we have been organizing on ICP banner and on scientific committee banner. Our leaders from Rajasthan, Dr. PRADYUMN Sharma, a very senior leader of API and a very big academician, Dr. GD Ramchandani, member governing body and a dedicated diabetologist of Rajasthan. So friends, today we are having webinar on potassium disturbances, and the speaker is none other than Dr. SANJAY PANDYA, who is very well known to all over India, but in Rajasthan, probably he has come 3-4 times in all API conferences. He is a very good orator and a wonderful human being, very simple man, such a big academician, but very simple man, a good human being. So I think it's a great opportunity for all of us to update ourselves about potassium disturbances from a man who is a experienced and a great orator, and he always speaks about, I mean, is a great experience in talking on electrolytes and acid-base balances. He has got mostly what I have heard him every time about this, and still we cannot update ourselves, and still we are feeling that we do not know about electrolytes. So over to our chairpersons, Dr. SEKHAR Chakraborty, Dr. MUNISH Prabhakar, and Dr. DP Singh.
Thank you, sir.
Over to you, sir.
Thank you, sir.
Yes.
I now invite Dr. SHASHANK JOSHI, past Dean,
Yes, sorry. Yes.
Editor, API Text of Medicine, for his address.
Thank you, Dr. Mathur, Dr. Munjal sir, our Director of PRF and our mentor, our lovable President, Dr. KAMLESH TEWARY of API, President of API, our Dean, Dr. RAJESH UPADHYAY of API and ICP, our other mentor and senior past President of API, Dr. PAREEK sir, Dr. GIRISH MATHUR, one and all, everybody. I think I congratulate this initiative, Dr. GIRISH MATHUR and a full team for this wonderful initiative on educating our physicians on topics which appear simple but can be very complex. And I think this virtual electrolyte symposium will energize our young and old and one and all through one of our most prolific speakers in Dr. SANJAY PANDYA, who has written a book on acid base and electrolytes on potassium, which is a very key topic today. And I congratulate Dr. GIRISH MATHUR, Dr. PAREEK for continuing your zest and zeal for the webinars. And that's something which is very laudable and exceptional. I also would like to place on record everybody who's there. We are all here to listen. Whatever we listen, we are here to learn. Whatever we learn, we should adapt. And I'm certain that the pearls of wisdom, Dr. Pandya and the team, which is going to be aptly moderated by very senior physician, Dr. PRADYUMN, SHARMA and Dr. RAMCHANDANI. And we have elegant chairpersons from our API stable in Dr. D.P. Singh, Dr. MUNISH, Dr. SEKHAR, CHAKRABORTY, and then Dr. N.P. Singh and Dr. RAJASTHAN, who are also like encyclopedias. Let us hope that we have a very fruitful dialogue discussion and we can at the end learn a lot of things which we can adapt to into our day-to-day practice. So congratulations and keep educating, learning, and I hope that we can adapt this knowledge into our day-to-day practice. Once again, congratulations to all.
Thank you so much, Dr. Shashank. I now invite Dean Indian College of Physicians, Dr. Rajesh Upadhyay, the man under whose leadership we are doing all these ICP CMEs, Dr. Rajesh Upadhyay.
Thank you, Girish. Good evening to everyone. It's a pleasure to be with all my luminaries and seniors from API here today. Dr. MUNJAL, who is my mentor, Dr. PAREEK, who is one of the most respected and regarded leaders of the API, Dr. KAMLESH TEWARY, who's our very dynamic president, my very close friends, Dr. SHASHANK, JOSHI, Dr. GIRISH, and we have with us the other luminaries from Rajasthan, Dr. Ramchandani and Dr. Pradyumn Sharma, and all the chairpersons. And I'm glad to see that Dr. N.P. Singh, after a long stint in America, is back in India as well. Dr. D.P. Singh is there, Dr. D.P. Singh and MUNISH Prabhakar. And it's a great to have all our people on a single platform, which is there for teaching and learning. And I'm really grateful. And this is, I'm speaking really from my heart. And I'm grateful to Dr. PAREEK and Dr. GIRISH for having taken the whole idea of teaching the postgraduates in a very, very excellent manner. And the topics which you are choosing and the way we are moving forward, I'm sure it's going to be of a great benefit to everyone. I certainly seem to enjoy and learn every day. So congratulations and many, many thanks for taking all this forward. And I wish you all the best.
Thank you, Dr. Rajesh. I request President API, Dr. KAMLESH TEWARY, for his words of blessings.
Thank you very much, Girish. Respected Dr. MUNJAL, respected Dr. PAREEK, other dignitaries from API, my team. First of all, I would like to thank Rajasthan chapter of API for inviting me on this occasion. And this occasion is created by none than by Dean Dr. Rajesh Upadhyay for postgraduate students. He has started a program for PG students and that is going very successful. And I should say that Rajasthan is the leader in this program. So I must congratulate Rajasthan people, Rajasthan API for this initiative. Other parts of country are also doing, like South, Kolkata, and also Bihar. Dr. GP Singh is also doing that program. But Rajasthan is ahead of that. So I will congratulate. And for today, it is Dr. Pandya who is going to talk on potassium imbalance. That will be very, very fruitful for us and for the students. With these words, I would like to bless this webinar a grand success. Thank you very much.
Thank you, Dr. Tiwari. So at Rajasthan, we are actually doing two sets of ICP programs. One is for general physicians, that is ICP CMEs, and today's program is one of that. Another is for exclusively for postgraduates, which is the master class, and Dr. Sanjay Maheshwari is looking at. So now I invite our mentor and guide, Dr. YP MUNJAL sir, for his blessings. Sir, please unmute yourself.
Unmute, sir.
Is that
Yes.
all right?
Yes,
Yes,
yes, sir. Yes, sir.
Dear Girish and our respected leader, clear-headed person, and who makes people motivated to follow or emulate him, Dr. KK Parikh, I think he deserves all our compliments. We have our president, Dr. KAMLESH TEWARY, who has done a yeoman service by adopting and letting people do something which is good for API at large. We have today's speaker in Dr. Pandya. I must say his grasp and presentation is so enamoring that you do not feel like stopping to listen to him. Dr. SHASHANK JOSHI, who has been at the forefront in Maharashtra on COVID-19 epidemic. He is a great orator and a very astute clinician. It is such a pleasure that I have been invited after the sodium imbalance for potassium disturbances. The lesson we learned today are that for electrolytes, not only the biochemical parameters, but ECG is a very important tool which we need to interpret significantly and well, and many differential diagnoses arise because of the electrolyte imbalance in the ECG. The galaxy of people who have been brought on one platform by Dr. GIRISH MATHUR, Dr. J.D. RAMCHANDANI is praiseworthy, and they continue to spread the message of education for all. I would like to congratulate that they have nephrologists, general physicians, and neurologists on their panel to discuss today's topic. The advantage is that the electrolyte, especially potassium, leads to disturbances in the cardiometabolism in a very, very significant way. So therefore, this is an important topic, and Rajasthan has been discussing topics like they discussed the critical care of the use of ventilators, which was attended by many. Similarly, after that, the sodium disturbances, and today it is the potassium. With these few words, I would like to once again congratulate the organizers and pay my special request and respect to Dr. Pandya, who is a luminary. I think what he has achieved as an author, I think few can achieve that height. So, Dr. Pandya, we are grateful that you have come to teach us once again with your masterly oration. Thank you very much, and thank you, Rajasthan, for inviting me.
Thank you so much, sir. We are grateful for your gracious presence. We now move on to our center program. I welcome our chairpersons, Dr. SEKHAR Chakraborty, Dr. MUNISH Prabhakar, Dr. D.P. Singh. I request our moderator, Dr. G.D. Ramchandani, to please introduce Dr. SEKHAR Chakraborty and Dr. D.P. Singh. And another moderator, Dr. PRADYUMN Sharma, will be introducing Dr. MUNISH Prabhakar. Dr. Ramchandani.
Good evening, sir. Honorable, respected seniors and legendaries and stalwarts of API, ICP, and PRF. And I think today is the great day for Rajasthan Forum of ICP Fellow. That's the only chapter of the ICP in the country to invite all the legendaries and international and renowned speaker, Dr. Pandya, for delivering this important lecture. And it's my great pleasure and honor for me to introduce the senior member of API, governing body member of API, Dr. SEKHAR Chakraborty. Dr. SEKHAR Chakraborty is the governing body member of API. He is a fellow of Royal College Physician, Glasgow, Ireland, and master of MRCP of Ireland. He is a senior fellow of Indian College of Physician also, and American College of Physician. He is a consultant physician and diabetologist, and a medical director of King's Diabetes Specialty Clinic and King's Hospital in Siliguri, and is a very active in Siliguri. Is doing regular CMEs, and previously we attended their CMEs also in that Siliguri, and a very good host also, and is a chairman of API North Bengal. He has many publications in the national and international repute journals, and is the author of API Update for last 6 years, and author of API Textbook of Medicine, and he has a editor of 2 monographs of ICP, dengue fever in 2016 and approach to chest disease in 2017, and is a contribution to the various other activities like PHFI and also there, and is examiner of MRCPA clinical examination. So I welcome Dr. SEKHAR Chakraborty for chairing this very important session. Welcome, sir. And our second chairperson.
Good evening. This is Dr. PRADYUMN Sharma.
Yeah.
Thank you, Dr. GIRISH MATHUR. Due regards to Dr. K.K. PAREEK, sir, who is the program head today evening. Due respect to guest of honors, Dr. JOSHI, Dr. RAJESH UPADHYAY, Dr. KAMLESH, TEWARY, sir. Evening chief guest, Dr. YP MUNJAL, sir. And my privilege to introduce Dr. MUNISH Prabhakar, who is the second chairperson of this evening. Dr. MUNISH Prabhakar, who is MBBS MD Medicine, FACP USA, FICP, FIMS Fellow Diabetes India, is elected member Haryana Medical Council, Senior Consult Physician Diabetes and Preventive Cardiology, member governing body National API, organizing chairman APCON 2015 Gurgaon, President Indian Medical Association Haryana State 2018, Vice President IMA Haryana State 2016, President IMA Gurgaon 2013-14, Member Advisory Board. Due regards, sir, Dr. MUNISH Prabhakar, you are welcome, sir. Thank you.
Welcome, Dr. Munish Prabhakar. So it's my proud privilege to welcome you all again. It's now I introduced Dr. DP Singh sir. It's my privilege to introduce Dr. DP Singh sir. And I can say one word that he was a true Corona warrior in last 1.5 years. And for that, he was awarded various awards from the various societies and various IMA and the Rotary Club also. So Dr. DP Singh is the governing body member of past 6 years from 2015 and presently is a member of governing body and a professor of respiratory medicine in Jalan Medical College, Bhagalpur, Bihar. He is a fellow of 3 international fellowship, that is a fellow of Royal College of Physicians, Glasgow and Edinburgh and American College of Physicians. He is a senior fellow of Indian College of Physicians and other fellowships also there. He is an eminent teacher and erudite clinician of internal medicine for the more than 36 years and is a recipient of several awards and honor. I also said previously, like Dedicated Teacher Award 2020, IMA Corona Warrior Award 2020, Rotary Corona Warrior Award 2020, and IMA National AKN Sinha Award 2018 and Dr. Pride Award 2020. He is an author of more than 43 national and international articles and books in various chapters. He is editor of 3 monographs of ICP, that is a guest editor of Journal of Special Issue of Chest Medicine of JIMA 2019 and 2020, and twice the guest editor of Patna Journal of Medicine. He delivered more than 225 lectures and chaired scientific sessions in national and international conferences. So I welcome Dr. DP Singh sir. Welcome sir for this session for chairing this session, sir. Thank you, sir.
Thank you, Dr. GD. I now request our chairperson, Dr. SEKHAR Chakraborty, to please introduce and invite our eminent speaker of this evening, Dr. SANJAY PANDYA. Dr. SEKHAR. SEKHAR, unmute yourself. Please unmute SEKHAR yourself. It appears there is some.
I think he is not there.
Yeah,
SEKHAR just left.
Some internet problem, I think.
SEKHAR, can you hear us?
He is muted.
Yeah.
Unmute ho gaya.
Yeah.
Am I audible?
Yeah,
Yes.
SEKHAR.
Yeah. So it's my good evening to all of you. It's my great pleasure and honor for me to chair this August gathering, and a renowned speaker, Dr. Sanjay Pandya, is here who will speak on fluid electrolyte imbalance. At the very outset, I convey my regards to my mentor, Dr. MUNJAL, Dr. KK PAREEK, Dr. TEWARY, and whole Rajasthan team, Dr. UPADHYAY, Dr. SHASHANK JOSHI, and along with my co-chairs, Dr. DP Singh and MUNISH Prabhakar. I am very glad to introduce Dr. Sanjay Pandya, who is a prolific speaker on acid electrolyte balance. In fact, when he came to Calcutta first, he delivered a lecture and the hall was full, and all postgraduate students, they are very much delighted. They were delighted to listen to his lecture. And I witnessed that Dr. Pandya is MD DNB Nephrology, and he's an author of the first Indian book on fluid and electrolyte and acid-base disorder, practical guidelines on the fluid therapy. This book has become very popular across the country, which itself it was sold more than 1 lakh copies, and it contributed chapters in various many other books and journals. And his contribution for the patient education immense. Actually, he is the pioneer in the education of the kidney patients and prepared book on prevention and care of common kidney disorders named Save Your Kidney. And this particular book has been translated in 37 languages. And all these the book, I think medical book has been translated in so many languages. This is the unique book available on the net also, and it is freely available. It's my honor to introduce and invite Dr. Sanjay N. Pandya. Sir, please now you proceed for the deliberation, sir. Hello.
Hello.
And Dr. Pandya, may I invite Dr. Pandya for his deliberation?
Am I audible?
Yes, sir. You're audible, sir.
Good evening, all giants and leaders of API, our chief guest MUNJAL sir, legendary stalwarts of API, Dr. SHASHANK JOSHI sir, our beloved Dean RAJESH UPADHYAY sir, API President KAMLESH TEWARY sir. The brain behind all this webinar, Dr. GIRISH MATHUR sir and PAREEK sir, all chairpersons, and my learned Dr. N.P. Singh sir and SEKHAR sir, who are going to help me to go ahead with this thing. Now, the first and foremost, I would like to let you know that when we talk about basics of potassium, brief physiological aspect, that potassium is the most abundant cation in ICF, in intracellular fluid, and it is 90%, 98% in intracellular fluid and just 2% in extracellular fluid. This potassium plays very important role in cell function and neuromuscular transmission. Basically, we will not go in depth of the regulation, but whatever potassium is consumed, it is after absorption is excreted chiefly through kidney. But when there is a large amount of potassium entry in the blood, there is an internal shift, and there is transcellular shift which prevents rise in serum potassium level. So internal shift is a prompt action which prevents hyperkalemia, and for the proper maintenance, excretion is a slow action which is done by kidney when it is functioning normally. Now, basically, two disorders which we are going to discuss is hypokalemia and hyperkalemia. Now, in hypokalemia, when serum potassium is less than 3.5, that is what we define as a hypokalemia, is a frequent disorders which we see in hospitalized patient in day-to-day practice. When the problem is mild, patient is asymptomatic, but when it is severe, we will have lot many symptoms which we are going to discuss. Now, basically, when we talk about hypokalemia, it is important to remember that most important cause of hypokalemia are diuretics, vomiting, and diarrhea. And there are many other causes which can be because of poor intake, non-renal loss, renal loss, or because of the distribution. we will not go in depth of everyone because I would like to concentrate more on clinical part, therapy aspect, rather than more of the etiology and physiological aspect. But there are many causes because of which we can have hypokalemia, and therefore it is important for all of us to remember basics about it. Now, when we approach the patient of hypokalemia with detailed history, the underlying problem is evident in large number of patients. And when it is not evident, at that time, we have to go for the further workup. Serum potassium level and ECG changes both together determines how is the severity and how quickly we should manage the patient. And therefore, looking at the ECG is something which is very, very important. The ECG changes of hypokalemia and hyperkalemia is very well defined in one of the articles which I have quoted here. And the simple thing is that it is push and pull effect. When you push T wave, then what you get in hypokalemia is T wave invasion, ST depression, and prominent U wave. While in hyperkalemia, it's like pulling T wave. So there is a peak T wave, there is P wave of flattening, PR prolongation, and widening of the QRS. So this is basic ECG changes. So serum potassium level and ECG changes together help us to clinch the diagnosis. When diagnosis is not evident, the basic couple of investigations which are very important are serum magnesium concentration, 24 hours urinary potassium excretion, and acid-base disorder. Basically, the urinary excretion is very important because whether there is low excretion or because of the high urinary excretion, we are having hypokalemia, that will help us to analyze the underlying problem. The most common problem which we encounter with low urinary potassium excretion is the diarrhea. On the long-standing diuretic use or patient who has frequent vomiting, they can also have low urinary potassium. When the potassium loss is high in such patient, to go ahead with its etiological diagnosis, we need to look at the two things. Number one, what is the pH, whether there is metabolic acidosis or there is alkalosis. And second is the blood pressure. When patient has metabolic acidosis, high urinary potassium excretion, normal blood pressure, the common causes are diabetic ketoacidosis, renal tubular acidosis, amphotericin B toxicity. When there is variable pH, renal salt wasting is common. When patient has metabolic alkalosis, then we need to look at the blood pressure. If it is normal, look at the urinary chloride level. If urinary chloride level is low, vomiting is the commonest problem. If there is high urinary chloride, then diuretics, magnesium deficiency, Bartter syndrome, Gitelman syndrome are the causes. When patient's blood pressure is high, the patient who comes to us with hypertension, hypokalemia, metabolic alkalosis, then the aldosterone is the problem. Aldosterone related, hyperaldosteronism related problem should we expect. So primary and secondary hyperaldosteronism, Cushing syndrome, renovascular hypertension are the common problem. So with this basic thing, now if we have a problem of hypokalemia, how do we plan out? There are three aspects. Number one, replace the deficit. Number two, the ongoing loss should be prevented. And third thing, that we need to treat underlying etiology, because otherwise whatever replacement done cannot raise the serum potassium level. Now, it's important to remember that when potassium decreases, the magnitude of the loss of the potassium from the body is sizable, and especially when serum potassium is 2 or less, that means patient has large amount of potassium deficit, and therefore we need to provide adequate amount of potassium with close monitoring so that patient is adequately treated and improves. Now, the danger of, we need to look at the dangers of the hypokalemia, muscle weakness, paralysis, cardiac arrhythmia are the problem, if not treated, can give rise to death. So always check for the symptoms, look for the ECG changes, because both together tells us that how severe is the hypokalemia. Now, when we have a patient where the hypokalemia is severe and symptomatic, such patient needs urgent treatment, aggressive treatment. Even those patients who have hepatic encephalopathy associated with hypokalemia can aggravate hepatic encephalopathy. Digitalis therapy can have complication, cardiac surgery, paralytic ileus. These are the patients who needs early treatment and adequate treatment of the hypokalemia. Now, we will not go in depth of the treatment of mild hypokalemia. So oral supplementation, I'm not going to talk. But when we want to replace it through IV fluid management, then how should we go ahead? Either we use ready-made IV fluid, which is available in market, or we add potassium chloride pint. So which are the fluids available, commercially available fluid, which we can use in day-to-day practice? Amongst all fluid, Isolite M, Isolite P, and Isolite G, they have a large amount of potassium. Isolite M is the richest because 35 milliequivalent, Isolite P is 20, Isolite G is 17. But the fluid like Ringer's lactate, plasma light, although they have potassium, it's just 5 and 4 milliequivalent, and therefore when you are using this fluid, you have to keep in mind that you are not able to replace potassium adequately, and we need to provide potassium in separate way. Now, separate addition, if we want to do, which are the agents available to us? Potassium chloride, most widely used, most frequently used, and in most of the patient, this is the molecule which is required. In small group of patients, we can use even potassium phosphate, about which we will discuss later on. Now, KCl infused, KCl ampule is available in 10 ml ampule to us. So how much potassium this 10 ml of KCl ampule contains? Answer is simple, that every 10 ml ampule contains 20 milliequivalent of potassium. So every 1 ml has 2 milliequivalent of potassium. So considering this potassium content, we need to plan out that how much potassium are we going to add in given fluid. Potassium phosphate is used sparingly, but is more potent, more concentrated form of potassium content. It's available in 15 ml ampule, and 15 ml contains 66 milliequivalent of potassium. So for every 1 ml, the potassium content is 4.4 milliequivalent. So we need to keep in mind that when we use 1 ampule of KCl, it's 20 milliequivalent availability of the potassium. When we use potassium phosphate, then in 10 ml, it is 44 milliequivalent. So for each ml of both this potassium containing concentrate, the amount of potassium in potassium phosphate is double. So when we are using this concentrate potassium additive, we have to dilute it adequately. Now, when we want to use KCl, the question arises that how safely can we use it? Answer is that when it is given intravenously, give it slowly, meticulously, under close observation. Don't give more than 10 milliequivalent per hour. Don't add more than 2 ampule, that is 40 milliequivalent in 1 liter of fluid. When large amount of fluid needs to be given, but it should not be more than 200 milliequivalent per day. And when you give such a large amount, close ECG monitoring is important. Periodic potassium checkup is important. don't add KCl to isolate M because it has almost upper permissible concentration, which is 35 milliequivalent per liter. We never give KCl direct intravenously because it can lead to sudden cardiac arrest. Administration more than 20 milliequivalent per hour requires cardiac monitoring. If it is 10 milliequivalent, we can give in ward IV slowly without any problem. If we need to provide larger concentrated form of potassium, then we need to use central line because it's very irritant, can cause thrombophlebitis and other complications. Now, for peripheral infusion, what we need is that without ECG monitoring, it can be done, and provide desired rate is 10 milliequivalent per hour or less. And then pint should not contain more than 40 milliequivalent per liter when we want to give through peripheral line. In central line, yes, you can provide more larger concentration, greater amount of potassium, and therefore, if we are planning to give more than 10 milliequivalent of potassium per hour, if our fluid or infusion contains more than 40 milliequivalent per liter, then try to use central line. To prepare KCl drip, which IV fluid should be used? Answer is that it's very important that we should use either saline or we should use half normal saline. Very important fact which we need to keep in mind that in severe hypokalemia, avoid 5% dextrose 5% pint as a diluent. Why? Because when there is dextrose containing fluid used as a diluent, it can stimulate insulin, and this insulin can push potassium inside the cell and therefore aggravate the hypokalemia. And because of this reason, whenever you are preparing KCl drip, use either saline or preferably half normal saline, because concentration, osmolality, if half normal saline is used, will be lesser, and therefore it is preferred. Now, when we have prepared the pint, we have prepared the drip, it's important that we shake bottle well, because KCl is heavy, it may settle down in the bottle, bottom of the bottle, and infusion may cause the harm. And therefore, shake this bottle well is something which is very important. In treatment of the hypokalemia, very, very important part of the story is that search and treat underlying etiology, because otherwise replacement done will transiently increase the potassium, but subsequently again land up in trouble. Now, if besides giving adequate potassium, besides treating underlying problem, if potassium is not improving, it's very, very important to exclude hypomagnesemia. Most of the time, when we deal with the hypokalemia, along with potassium, we check even serum magnesium, because hypomagnesemia is common. And along with the potassium, we co-administer magnesium so that our response to treatment becomes adequate. Now, coming to coexisting disorder, that suppose patient has metabolic acidosis along with hypokalemia, which disorder will you treat first? Whether you will treat metabolic acidosis, which also requires treatment if it is severe, and hypokalemia also needs the treatment. But when the acidosis is corrected, it can, because of the change in the pH, because of its metabolic alkalosis effect, will shift potassium in intracellular compartment, and that may aggravate hypokalemia. So in severe hypokalemic patient, please first correct potassium to some extent, then continue potassium, and subsequently add bicarbonate. This is something which is very important. In metabolic acidosis with hypokalemia, immediate goal is prevention of potentially life-threatening arrhythmia, and therefore correcting potassium is important. correct neuromuscular dysfunction by raising serum potassium level to safe level. This is something which is important. Now, once potassium reaches to greater level, we try to provide bicarbonate along with the KCl. So this is something which is very basic. Now, we frequently manage patient of diabetic ketoacidosis. Now, whether potassium supplementation is important and why it is important, it is something which is important to discuss today. In diabetic ketoacidosis, suppose potassium is normal, then should we provide potassium, or we should provide potassium in DKA only when potassium become low, is something which is very, very important question, and all of you should pay attention to it. See, even if serum potassium is normal, estimated total body potassium deficit is 3 to 5 milliequivalent per kg in patient with diabetic ketoacidosis. Now, why patient with DKA develops hypokalemia? Answer is that it is because of the shift of the potassium. See, when we start therapy, insulin is given that is going to shift potassium intracellularly. Ketoacidosis get corrected. So correction of the metabolic acidosis will shift potassium inside the cell, and by this mechanism, the potassium will become low. Second thing, that the patient of DKA has loss of the potassium because of diuresis secondary to hyperglycemia. When acidosis is corrected, bicarb increases, kidney retains sodium and bicarbonate at the expense of potassium. So hypovolemic metabolic diabetic ketoacidosis patient to retain sodium and bicarbonate will excrete potassium, and associated vomiting is also cause of the loss of the potassium. So shift of potassium, loss of potassium, and dilution. When there is volume resuscitation, the dilution will get corrected, and because of all this reason, patient of diabetic ketoacidosis is likely to develop hypokalemia and needs supplementation. So what is the guidelines? How we should treat it? Look at the serum potassium level and plan treatment accordingly. If serum potassium is greater than 5.3, observe. Avoid potassium supplementation at this stage. So don't treat high potassium, which is more than 5.3. If it is normal, between 3.3 to 5.3, then this patient needs KCl supplementation 20 to 30 milliequivalent per liter once patient gets good urine output. So usually we feel that, oh, potassium is normal, so we shouldn't give it. But that rule does not apply in patient of diabetic ketoacidosis. Always treat even normal potassium in patient with diabetic ketoacidosis. When it is low, less than between 2.5 to 3.3, then the fluid which we are infusing should contain 30 to 40 milliequivalent per liter of potassium. And when it is extremely low, the first thing which we need to keep in mind that hold insulin. Don't give insulin because it can further lower down the potassium concentration. So first provide KCl, try to bring potassium greater than 3.3, and then along with potassium infusion, you can start providing insulin administration. So this is something which is important. And while treating such patient, what is the goal? The goal is to keep potassium level between 4 to 5, and for that, closely monitor potassium while treating diabetic ketoacidosis. So this was something basic regarding hypokalemia. Now going to second important problem is the hyperkalemia. This hyperkalemia is a life-threatening problem serum potassium greater than 5.5. So although hyperkalemia is less common, but it is potentially dangerous, and therefore we need to keep in mind and should diagnose it properly in day-to-day practice. Now, etiologies are many, but renal failure with excessive potassium intake and RAS blocker, various drugs are the most common cause of hyperkalemia in day-to-day practice. When we look at the causes or risk factor for the hyperkalemia, CKD, AKI, diabetic patients are more prone, patient with decompensated congestive heart failure, patient with impaired renal failure receiving potassium supplementation, and medication. Various medication, as all of you know, inhibiting renin release, inhibiting aldosterone release, and blockage of the sodium channel blocker are the one who carries risk of the development of the hyperkalemia. Now, when potassium level is high, before clinching and before saying that, oh, let us start therapy, it's important to even exclude pseudo-hypokalemia. Now, this pseudo-hypokalemia is not, I mean, it's a falsely elevated potassium concentration. The common cause is why even though patients' serum potassium is normal, it is likely to be high in some of the reports because there is a platelet rupture during coagulation. The tourniquet, which is tied while collecting the blood, if it is for more than 1 minute, or repeated clenching of the fist, is going to cause the hyperkalemia when reports are done. If the sample collected is kept in high storage temperature, that is also likely to cause hyperkalemia. Optimum temperature is 15 to 25 degrees centigrade. Increased thrombocytosis more than 6 lakhs is likely to cause pseudo hyperkalemia because on storage it may release the potassium. Now, sometimes the discussion, at least is this update European Society of Cardiology May 2021 has taken this point as one of the important point, and they said that which sample should we collect to measure potassium, whether it is serum or it is plasma. Serum is when we collect blood in plain bulb and blood gets coagulated and then we get serum, is the serum sample. While we add heparin and don't allow blood to clot, and then the upper portion plasma can be tested for serum potassium. So both can be used to measure potassium level, but plasma is preferred as per this latest cardiology update, because the risk of pseudo hyperkalemia is less when plasma is tested for potassium. So this is something which is basic part. Now going to treatment aspect. This treatment aspect is something which is very interesting because we have many agents available. Insulin, bicarb, salbutamol nebulizer, dialysis, loop diuretics, calcium, cation exchangers. So question arises that if we have a patient with hyperkalemia, severe hyperkalemia, how do we start the therapy and how these agents act? Now, there are temporary measures where the cardioprotection to stabilize cell membrane, we use calcium gluconate. There are agents which leads to redistribution. It shifts potassium into cell. So from ECF to ICF, potassium is shifted. And for that, insulin, nebulized salbutamol, bicarbonate causing metabolic alkalosis are the agent which is used. Then removal of the excess potassium, that is a specific therapy. See, these were all transient and temporary shifting or protection, but removal is done by loop diuretics, cation exchangers, and dialysis. And very, very important, always determine and treat underlying etiology. So if patient is getting potassium supplementation, prevent it. Taking LONA, stop it. SEARB, spironolactone, and other agents which we have discussed should be discontinued. Now the question arises that out of all these agents, which one should we start first? Which injection or which modality should be used as the first modality? Answer is that it's calcium gluconate. It is the first measure to use to treat hyperkalemia. How fast it works? Works fastest, but has shortest period. How much dose is given? 10 ml ampule is available of calcium gluconate. Calcium gluconate is most widely used because it can be given through peripheral vein. Calcium chloride can be used, but it can be given only through central line, and therefore during emergency, the calcium gluconate is the most widely used agent, and that is the first agent because it has a cardioprotective effect. So 10 ml is given in 10 ml of calcium gluconate is given over 2 to 3 minutes and repeated after 5 minutes if ECG changes persist. The repetition of the calcium can be done at least 2-3 times as long as we don't develop hypercalcemia and as long as patient is not stabilized. The onset is fastest, but it's a short acting and therefore should be given repeatedly. Now, which is the second measure? After calcium gluconate, which agent will you select as a second modality? Answer is that insulin and glucose is the second measure used to treat hyperkalemia. See, insulin is the fastest, most consistent and reliable treatment to lower serum potassium. Calcium does not lower potassium. It gives protection to heart. But for reduction of the potassium, it's the insulin, which is fastest and most powerful. It is indicated in all patients in emergency. So when there is emergency after calcium, start providing insulin. And once you are providing insulin, glucose must be given with insulin to avoid hypoglycemia. Monitor blood glucose to identify and treat hypoglycemia in time. Plasma potassium concentration will fall by 0.5 to 1.5 milliequivalent per liter. Now, how fast it takes? It's not, I mean, the calcium acts within minutes, but insulin will take about 5 to 10 minutes to act and effective for about 4 hours. And therefore, we need to repeat insulin at every 4 hourly if the potassium is not controlled. Now, how to administer insulin? The bolus of 10 units of regular insulin injection is recommended, followed by either 50 ml of 50% dextrose, or in our country 100 ml is available, and therefore that is usually provided immediately after providing bolus of insulin. Now, the role of the glucose is to prevent hypoglycemia. But if patient is diabetic and the baseline blood glucose is greater than 250 ml, then we may not give insulin to such patient. We will monitor it closely. If they develop hypoglycemia, then we may provide it. Some of the patients who are likely to have lower side of the blood sugar, the policy is to provide slowly dextrose 10% round the clock to see that they don't get hypoglycemia. Now, some of the patients are more prone to develop hypoglycemia, and these patients are of renal failure, lower weight, malnutrition, and others. Now, after calcium, after insulin, which agents will you use next? The two agents which we are considering is bicarbonate and salbutamol nebulizer. So which is preferred? Which is more potent and more preferred? Answer is that beta-2 agonist salbutamol is the third measure to use to treat hyperkalemia. It is effective but underutilized. People feel that no, it may not be that effective. But so as a third agent, we should use this thing. There is an increased need to increase awareness of using this agent rightly. So high dose of the salbutamol is given as a nebulizer slowly over 10 minutes. onset is within 15 to 30 minutes, and effect lasts for about 4 hours. Potassium reduction is also reasonable. After 4 hours, it can be repeated. The error which frequently seen in ward is about using dose. We for bronchodilation use Respule. Respule of Asthalin is available in 2.5 milligram. Now, usually one Respule 8 hourly, one Respule 6 hourly nebulizer we are giving. So, whenever we say that to start Asthalin nebulizer, the resident junior doctor will start with either 1 or 2 dose. But it's important to remember that bronchodilator dose is 2.5 to 5 milligram, so 1 ml solution or 2 Respule. Against that, in hyperkalemia, the dose required is 4 times greater. So the dose required is 20 milligram or 4 ml if we are using solution, or as high as 8 Respule. So giving 1 Respule nebulizer and believing that, oh, we have treated hyperkalemia is an error. Either give 4 to 8 Respule and monitor them closely. The sodium bicarbonate is the 4th measure which we use in treatment of hyperkalemia, and we should use it selectively and not routinely. Why selectively? Because it is effective in non-anion gap metabolic acidosis. If the pH is normal, then effect is going to be, there is no effect of this agent because it's not going to act, and less effective in high anion gap metabolic and metabolic acidosis and in renal failure. It has many complications, hypocalcemia, tetany, exacerbation of the erythemia, sodium load, aggravate congestive heart failure and renal failure, and therefore, unless you have proven metabolic acidosis along with hyperkalemia, don't use this word. Now, potassium binding agents, the widely used K-bind sodium polystyrene sulfonate, we are using for decades together, but is comparatively less effective and has certain problems like colonic necrosis, and therefore is used judiciously. Newer from last 5 years, the 2 new agents have appeared in literature, that is petiromol, and more impressive is sodium zirconium cyclosilicate. This agent binds potassium in exchange of the HIN and sodium. Time of onset of this agent is very fast. It is within 1 hour. This data is from AJKD 2019. But unfortunately, these newer agents are not available in India, and therefore we need to go ahead with proper care of underlying problem, proper hydration, treatment of hyperkalemia by prompt measures, that is calcium gluconate, followed by insulin, followed by nebulizer, and selectively bicarbonate. Use potassium binding drugs when required, and in small group of patients, when patient is not responding to other therapy, patient is oliguria, patient is renal failure, then dialysis is the most effective out of all modality. The most and best effective therapy is dialysis, but is not possible in each and every patient, and therefore is used selectively. With this, I would like to end my talk. Would like to thank for supporting this book. Would like to thank for supporting kidney education activity, which is in 38 languages, proud of India, World Record Award winner, available in 26 international languages and 12 Indian languages, received 9 crore hits. Book is available free to read online, can get even on WhatsApp free. It's a outstanding work of more than 100 nephrologists across the world who has provided their dedicated efforts and provided this educational resource totally free. My hats off to all busy clinicians who has taken paying to prepare 200-page kidney book in their mother tongue. The giants, global giants like President International Society of Nephrology, President International Federation of Kidney Foundation, they also prepared this book in their native language. Widely appreciated by American Society of Nephrology, World Kidney Day website, European Dialysis and Transplant Society, which are globally giant nephrology society, and therefore all of them are supporting this activity. We are blessed. With this, I would like to end. Thank you very much for giving me this opportunity and listening on talk of the hyperkalemia. I have very learned colleagues, Dr. N.P. Singh sir, Rajkot sir. With them, I would like to go ahead with a question answer and further discussion.
Thank you, Dr. Pandya. Yours was excellent, magnificent. I was simply spellbound. Thank you so much, sir. We move on to our panel discussion, and for that, I request our chairperson, Dr. Munish Prabhakar, to introduce our panelist, Dr. N.P. Singh, and I request Dr. D.P. Singh, to please introduce Dr. Raj Sekhar. Dr. Munish Prabhakar.
Hello. Hello.
Hey, Dr.
Yes,
Prabhakar,
yes,
you're
you are audible. You are audible.
Yeah. Good evening, everybody. It's my proud privilege to introduce our panelist, Dr. N.P. Singh, one of the medical luminary whom I have been associated as a colleague in my API, as well as knowing him for his medical acumen. Presently, Dr. N.P. Singh is Director of Research and Professor and HOD at SGT University, doing great research work. And in the past, he has done lots of human work as Head and Director in Maulana Azad Medical College as a very eminent nephrologist. And later, he shifted to Max Hospital and had been doing great service for the humankind. One thing I can say about Dr. N.P. Singh is that his medical knowledge, his explanation are so simplistic and so good that it is always treat to have him as our panelist.
Thank
I
you, sir.
request him to give his opinion and about the things, because if I keep on telling about his achievements, that will take a lot of work of a lot of time of this panel discussion. So I request the other panelists and to join and request Dr. N.P. Singh to give his deliberations.
Thank you. I think there will be a question answer session. So once the question comes up, then I'll be able to answer. Thank you, Dr. Prabhakar, for your very, very nice words. Thank you.
Thank you, Dr. Monish, for a nice introduction of our friend, Dr. N.P. Singh, sir. And now is, first of all, I must congratulate Dr. Sanjay Pandya. Never before we have listened or heard about the so wonderful talk on this hypokalemia, electrolytes, this equilibrium. Hats off to you, very well. And so slides were so nice. That is so beautiful that even the difficult thing you have made easy. Excellent. Congratulations time and again, Dr. Sanjay Pandya. And now it's time for me to introduce my friend who needs no introduction at all. I think he is none other than our friend, Dr. R. Rajshekhar. Rajshekhar, you can say, although he has got this fellowship of Indian College of Physicians, fellowship of American College of Physicians, he's a triple FRCP and whatnot. But what I am so impressed by Dr. R. Rajshekhar, that he symbolizes Dr. Mr. Medicine Update. Every morning you can get the latest information from latest journal, whether it is national or international, and he will put something with this MCQ, and really we enjoyed his MCQ. He is such a finest writer. He is an author, or you can say father of mnemonic. It's a very good book. He has got 4 or 5 ICP monographs. One is that electrolyte imbalances also. this anemia and others, so many. And plus, he's a prolific orator. He's a yes, delivered many talks, oration, state and national conferences, and he's editor of Yearbook of Medicine 2018, 19, and 20, and he has written more than 100 articles in API Medicine, Progress in Medicine, JAPI, JIMA, medical journals, and lastly, and he deserves that he was bestowed upon Master Teacher Award by API 2020, and thank you to be, and it's an honor to be welcome Dr. Rajshekhar in the panel, and beautiful, wonderful speaker and wonderful panelist in Dr. MP Singh and Dr. R. Rajshekhar sir. Most welcome, Dr. R. Rajshekhar.
Thank you. Thank you.
Thank you, Dr. DP Singh. I request our moderators, Dr. G.D. Ramchandani, Dr. PRADYUMN Sharma, to please proceed with the panel discussion.
Thank you, Dr. Girish. Let me congratulate Dr. Sanjay Pandya. It's a beautiful oration, beautiful, outstanding and awesome. The way the slides have been prepared, the way slides have been delivered, and the way that it has gathered the information, highly regarded, awesome. I believe and I give a standing ovation. So this time, the first ball of the question and answer goes to Dr. Rajashekhar. We believe that the kidneys and the liver are the two exit points. And this time, today's the evening goes for the kidney now. And as with the, how can natriuretic agents cause increased renal excretion for potassium? Number one. And what are the other multiple factors for renal potassium loss? Over to Dr. Rajashekhar, sir.
Thank you. Thank you, Doctor. Thank you all panelists, moderators, and all the senior colleagues, and Dr. Sanjay Pandya. I am always keeping his book in my bed. I sleep with his book only because such a wonderful book. I am not exaggerating. I am still keeping his book on the table. So with that, so how do natriuretic agents increase renal excretion of potassium? We know what are the natriuretic agents. The first and foremost is loop diuretics, that is furosemide, torsemide, ethacrynic acid, bumetanide. These are all the loop diuretics. Thiazides, we know, thiazides 2, one is hydrochlorothiazide, another is chlorthalidone. And then acetazolamide, which is a carbonic anhydrase inhibitor, but it is a weak diuretic. They all, how do they result in increased renal excretion of potassium? It is very simple. It leads to increased sodium delivery to the distal nephron. Please note, it increases the increased sodium delivery to the distal nephron. So that's causing volume depletion and increased aldosterone secretion. So subsequent increased renal potassium excretion. That is how the hypokalemia is being caused by the natriuretic agents. And also we know there are other major routes of potassium loss, that is gastrointestinal route, that is nasogastric suction, vomiting, and so many things. And already has highlighted the multifactorial renal potassium loss, that is alkalosis, volume depletion due to increased aldosterone secretion, then increased loss of hydrochloric acid in gastric fluid, which leads to a high tubular concentration of bicarbonate, a relatively non-absorbable anion. So this is how the natriuretic agents cause hypokalemia and GI fluid loss hypokalemia. Thank you.
Thank you, Dr. Rajshekhar sir, for a wonderful simplified explanation of how to these drugs causing hyponatremia, these natriuretic agents. So now we are moving to the next question. Next question is, what is pseudo hyperkalemia? That Dr. Pandya already briefly explained, but I request Dr. NP Singh sir for his comment about this pseudo hyperkalemia.
I think it is very essential when we see a lab report of potassium higher than the normal value, we must look at the patient as well. We must look whether the patient is symptomatic and more importantly, whether there are ECG changes which suggest hyperkalemia. Why I feel, and it's well known that pseudo hyperkalemia is much more common than actually thought of, because of, especially in India, because of the mushrooming of the non-calibrated labs. So two important components which can cause pseudo hyperkalemia has been alluded to by Dr. Sanjay Pandya is when you clench your fist while, and it is very common occurrence that when you ask the patient to donate, to give blood, and the technician will put a tourniquet, and also he will ask the patient to clench his fist. Both of them, through various mechanisms, by either a RBC rupture, mechanical rupture to the RBCs, or because of the platelet aggregation, can cause a slightly higher potassium level. Now, what is more important is whenever we see such cases, we must repeat the potassium level, and that time we must ensure that tourniquet is released the moment the needle is inside the vein, and also do not ask the patient to clench his fist. Both these maneuvers have been very gratifying in trying to give to the patient, especially this so-called mild hyperkalemia has been seen very commonly in pre-operative patients. And there, the anesthesiologist in the morning will refer to you that why this is occurring. So we must look at the symptoms, and we must look at the technique of the blood draw. Apart from that, there are various other causes, as has been alluded to. Platelets, any increase in 1 lakh platelets can elevate the serum potassium by around 0.17 or 0.2. And when it becomes, in certain conditions, when thrombocytosis is there, then pseudo hyperkalemia can occur. Similarly, in patients who have leukemia, lymphomas, or any condition which gives rise to leukocytosis or leukemia, there also, because of the cell degeneration, because of the secretion of the potassium from the cell outside the cell of extracellular fluid, all this can cause hyperkalemia, which may or may not be related to the type. So that is why there is, as he very rightly pointed out, there is a serum, there is a plasma. We must ensure that though heparinized blood is better, and that is why you get plasma, but in the second part, I'll like to also contribute the cause of hyperkalemia due to heparin as well. So heparin not only will not result in pseudo hyperkalemia, but can contribute significantly to mild hyperkalemia because of its ability to decrease aldosterone. So I think each clinician should understand that when the patient is asymptomatic and when the patient does not have ECG changes, we must ask them to repeat the potassium level.
Thank you, Dr. N.P. Singh. That's very truly sad. You have to be primarily a clinician, not a lab man.
That's
what are the lab findings you see, but you have to make them relevant in clinical scenario. That's one of the reasons to diagnose a pseudo hyperkalemia. So back to over to Dr. Sanjay Pandya, sir. We understand that the potassium disturbance has had a lot of impact on the muscle, cardiac, and on the nerves also. But can you highlight what are the major endocrinological causes of potassium disturbances?
Basically, aldosterone is the one which acts on the kidney, and it retains sodium and excretes potassium. So excretion of the potassium is determined basically strongly and chiefly by aldosterone. So any problem, any underlying endocrinal problem which either increases the aldosterone, like hyperaldosteronism, primary or secondary, whatever may be mechanism, or if there is aldosterone deficiency like Addison's disease, in such patient, potassium problem is likely to occur. So this is the main underlying problem, endocrinal problem, which we can see and can have potassium problem. See, hypertension, basically all of us see hypertensive patient, but the commonest hypokalemia and hypertension, commonest cause can be even strong, and therefore this is the most important thing which we should keep in mind. And second thing which I have already discussed is that diabetic ketoacidosis is a problem where potassium is many a time overlooked. So that needs emphasis, which I have already discussed.
Unmute kare sir, Dr. Pradyumn.
Sorry. So thank you. So back again to Dr. Sanjay Pandya. This ball comes back again to you, sir. So how do you find that the hypokalemic periodic paralysis has a lot of impact? And we understand it's a really big scenario and has a big clinical impact. So can you tell us how is the global impact, how the percentages has a clinical relevance, and how will you manage? Kindly just let us know, sir.
See, hyperkalemic periodic paralysis is comparatively a rare disorder. It's a familiar disorder seen less frequently, and its precipitating factor is like heavy exercise or fasting or heavy meals. And in such patient, we land up and we encounter hyperkalemic periodic paralysis. Basically, when patient comes, then management is same as that of the other hypokalemic patient, but we need to replace potassium cautiously, because once it is controlled, then the potassium which is infused is going to stay in the body and may subsequently cause hyperkalemia. So don't try to treat this problem aggressively. And second thing, that once it is controlled, it is treated, the next step which is essential, which we need to keep in mind, is the prevention of a hyperkalemic periodic paralysis. And for that, the drugs which is suggested and used are carbonic anhydrase inhibitor and potassium sparing diuretics like spironolactone, which we use for cirrhosis and congestive heart failure.
Just to add to it, Dr. Pandya, I think he had earlier pointed out that there's an importance of giving potassium. We must ensure that we avoid giving it in dextrose or even saline for that matter. Both the dextrose will further push the potassium inside the cell, and also saline may dilute sodium or potassium. So we need to have a proper carrier. It can be mannitol or anything, or as he rightly pointed out, even oral potassium can be adequate enough. We need to understand that these patients have a problem of the membrane, and they are extra sensitive to potassium, sodium, potassium, ATPase channels. So even a lower level of potassium, a mildly lower level of potassium, can significantly cause periodic paralysis in a patient who is genetically more prone. So that needs to be understood. Very rarely, a very severe amount of hypokalemia can cause also periodic paralysis. But generally, as he rightly pointed out, young males genetically predisposed mild hypokalemia, and especially after food and other things.
Exercise.
Thank you.
One thing, excuse me, Dr. GD Boss, please. Dr. Singh, would you like to have such a patient who have a predilection for hypokalemic periodic paralysis to have certain foods which are high in potassium levels? Would you like to have it then put it on a regular basis?
Yes, we can also give food supplements, but by and large, many of the foods which are high in potassium, like fruits, etc., are high in glucose also. And this can be counterproductive, and it can push the potassium inside the cell. But you are right, there are certain specific potassium, higher potassium products like bananas, etc., or like coconut, that can be given to such patients. There is no harm.
Thank you, sir. Thank you for your expert comment about this hypokalemic periodic paralysis, sir. Now we move to the very practical problem in hyperkalemia. That is, in day-to-day practice, we commonly use many drugs in hypertension, and mostly ACE inhibitors and ARBs. Both are culprit for this risk for the hyperkalemia. So my next question is senior faculty, Dr. Rajkot, that can we find any difference in the risk for the hyperkalemia, and whether we are using ACE inhibitors or ARBs, sir?
Yes, the risk of hyperkalemia that is caused by ARBs is almost similar to that of angiotensin converting enzyme inhibitors. Though in many large scale clinical studies, the frequency was found to be less with angiotensin receptor blockers than with angiotensin converting enzyme inhibitors, although the exact reason is still not clear. It may depend partly on the differential degree of inhibition of aldosterone. Again, what Dr. Sanjay Pandya told, aldosterone is very important. Differential degree of aldosterone inhibition with these two classes of drugs. That is the reason.
Thank you, sir. Dr. PRADYUMN?
Yes, sir. So we understand a lot of talking about hyperkalemia. Dr. Singh, there's a one question. I've been looking for the foods causing the hyperkalemia and the potassium content in the foods. So I took that the banana, we dealt with in carrying the masses, the banana carries the highest potassium, that's around 400 milligram in a one banana. But there was one issue also, so the baked potato that carries twice the number, the potassium of a banana, because a banana carries 400 milligram. It is a baked potato one that carries 835 milligram potassium. So how do you comment it on, sir?
Now, let me combine the other question as well, which I was asked to do about causes of hyperkalemia.
Yes,
Let me make you understand, in the normal adult, oral intake of potassium will not lead to hyperkalemia, because one, even if we take a very, very high amount of potassium, it will only cause a very mild transient increase in serum potassium level. And then there is a rapid potassium adaptation. This will occur because of prompt excretion of potassium from the urine. In fact, there have been studies which have shown that if you give a very high rich potassium diet to rats or to animals or to individuals, human beings as well, within a span of 48 hours, the urinary potassium excretion increases significantly, so that the serum potassium is slightly maintained at a high rate. Now, what are the true actual causes of hyperkalemia are when your body is not able to excrete the potassium. So two factors which can cause hyperkalemia apart from the dietary intake is inability to excrete urinary potassium load, which can be either because of its action on aldosterone, that is low aldosterone levels, or there is a low sensitivity of the tubules, the distal converted tubule to the aldosterone, or because of the acute or the chronic kidney disease. Now, all the drugs, all the other things which have been talked about are actually acting through these two mechanisms. The second more important one is when there is a transcellular shift, inability of the transcellular shift, because we know that potassium stays inside the cells. So whenever there is a cell degeneration, whether because of the rhabdomyolysis or whether because of certain drugs, like we talked about beta blocker, we didn't talk about beta blockers, or whenever there is a condition in which there is a cell turnover is increased, then the potassium from the cells can increase. But in practice, each one of us know that hyperkalemia is multifactorial. Certain contribution by the drugs, like NSAIDs, very commonly NSAIDs are being taken. Dr. Rajeshekar talked about ARBs. In patients with diabetes, now Dr. Pandya did touch upon this, there is a condition known as hyporenemic hypoaldosteronism. That is, even with a slightly lower level of serum creatinine of 1.5, these patients have a low aldosterone and a potassium of 6. So we need to understand that in our clinical practice, most of the persistent hyperkalemic patients are generally having a multifactorial. It can be drugs, it can be increased oral intake, it can be because of mild CKD, it can be because of the shifting of coming out of the potassium from the cells. So, but by and large, all causes of hyperkalemia are related to either increased potassium release from the cell, whether you call it a pseudohyperkalemia, metabolic acid. He did allude to about metabolic acidosis. Metabolic acidosis can cause mild hyperkalemia, but not because of ketoacidosis and other organic acidosis. But in diabetics, there are various other mechanisms he did talk about. Then there is an increased tissue catabolism, which can cause hyperkalemia. Beta blockers, again, very, very important drugs, which are very commonly used, labetalol or earlier used beta blockers. Then, of course, there are, as I said, there is the reduced urinary potassium excretion. Rarely, there are certain conditions which can actually, as he said, dehydrated state, reduced distal sodium and water delivery can also reduce the effective blood volume, and patients with heart failures, patients with cirrhosis. Now, again, multifactorial. These heart failures are on ACE inhibitors in ARBs, and all these can contribute to hyperkalemia. So foods alone, in fact, it is said that normally high potassium diet is very good for a normal human being. It may even prevent a lot of bimaris, including hypertension.
Thank you, sir.
Another non-cardioselective beta blocker, that is propranolol. Because apart from labetalol, why non-cardioselective beta blocker beta 2? Because so simple, because the cell membrane is beta 2 mediated.
Yes, absolutely.
Thank you, sir. Thank you, panelists, for your expert comments. Now we are moving to the next question, that is, in severe hyperkalemia, as Dr. Pandya has already briefly explained about number 1, number 2, number 3, number 4 treatment, and now very clearly and very simplified the way they explained. But still there are few things are missing, that in treatment of severe hypokalemia, we are using first calcium gluconate, then insulin, and when to reduce the dose of insulin and why?
Basically, insulin is a very potent, I mean, the first line and most potent agent which will shift potassium inside the cell. But the problem is that it carries risk of hypoglycemia. Now, diabetic patient with baseline high blood sugar, this risk may be less. But those patients who has impaired renal function, in such patient, they are more prone to have that the insulin effect will be extended. So in patient with renal failure, insulin effect will be extended. Even with lower dose, they are likely to develop hypoglycemia. So very, very important that if patient has high creatinine, then give lesser dose, 5 units or 6 units of insulin is enough. Second thing, that those patients who are low weight, in such patient, the same dose becomes higher and they are prone to cause hypoglycemia. A malnutrition patient, many of the patient we said that there will be refeeding syndrome, and in such patient have hypokalemia. So if they have by chance hyperkalemia due to TPN or other causes, and if we are giving insulin, we need to give low dose. So this is something which is very, very important. Special precaution in patient with renal failure. And as I mentioned, some of the patients who are prone to develop hypoglycemia, with insulin, we give dextrose is one part, but then subsequently giving infusion of dextrose 10% slowly will help to prevent hypoglycemia.
Thank you, Dr. Sanjay Pandya. We believe and we understand that a lot of the drugs there are in the prescription, they influence electrolytes. And it has been observed that the PPI overall the globe is the highest rated drug which has been occupying the prescription many times. May not be the rightly said, but it is PPI is being associated in GI prescriptions, in ortho, in surgical prescription, and neuro prescriptions also. So, Dr. Rajashekhar, how will you believe PPI therapy influencing electrolytes? If so, how and what are the risk factors associated?
See, we all know many patients without compelling indications, they are on proton pump inhibitors. So there is much of evidence showing it increases the mortality. How do they influence the electrolyte channel to cause increased mortality? So we all know there is a worldwide evidence of the proton pump inhibitors. And also there is also a magnesium deficiency, that is hypomagnesemia and QTC interval prolongation. So how do they occur? There is one entity called the gene-related HERG channel. So it influences that channel, it blocks, and that's how the QTC interval prolongation and causes the arrhythmias and problem. So that is how, that is the latest, there is a very recent article on proton pump inhibitors and related, a gene-related HERG channel. So that is evaluated in HEK293 cells. It's a very recent article. So it is very well documented. So we have to be careful. Without compelling indications, it should not be, no drug has to be prescribed, including proton pump inhibitors. Thank you.
Thank you, Dr. Rajashekhar. There's one question. In COVID era, there have been a post-COVID complication as a fungal infections, yellow fungus, white fungus, or the black fungus. And the drug most commonly used was the indicator was a liposomal amphotericin B. And this liposomal amphotericin B affects the magnesium, though the potassium also. Primarily the potassium is hit and the magnesium. And there's been a lot of controversy, a lot of misunderstanding and not knowing about the electrolytes and the impact of amphotericin B. So how will you address, because still there are many of the cases of fungal infection in the market, sir?
So we have to be careful. Please, sir. Sanjay?
Yeah, see, basically, magnesium is something which is very, very important, because hypokalemia and hypomagnesemia, when both are together, the magnesium leads to potassium wasting. And therefore, unless we give potassium, adequate magnesium, this wasting will not be prevented. And if whatever amount you give, larger amount of potassium you provide, it will be excreted in the urine, and therefore first thing will be provide adequate magnesium, which will prevent magnesium wasting, and subsequently potassium provided will be retained, and therefore treating magnesium, suspecting hypomagnesemia. See, amphotericin B is a classical example where both exist together, but even in other cases, the magnesium can be deficit, and therefore hypokalemia and hypomagnesemia both should be considered together. As I had mentioned, when you have a patient of hypokalemia, always ask for the magnesium report and treat it adequately.
Just to add, Dr. Sanjay, we know that amphotericin B actually gets highly concentrated in the tubules, proximal convoluted tubules, where both potassium as well as the magnesium are getting absorbed. So it is, in fact, before causing nephrotoxicity, if you want to suspect a nephrotoxicity due to amphotericin conventional or now liposomal, then we need to do a urinary potassium and magnesium level, look at the urinary, and they are the first to act. And that is the mechanism by which these patients can have hypokalemia. And very rightly pointed out, Dr. Sanjay, that we need to correct. In fact, if the patient is not improving on potassium therapy, always look at magnesium, and simultaneously, as he rightly said, and this is a very, very important take-home message from all of us.
Thank you, sir. I think the management part of, yes.
See, not only amphotericin B, a simple beta-2 agonist, as Dr. Sanjay Pandya has told, bronchial asthma, we are giving left and right salbutamol. So they are potential cause. It is, in fact, it is one of the agents for treating hyperkalemia. It is being used for bronchial asthma. So they are potent for hypokalemia also. So that's why we have to be careful. We can give even magnesium sulfate for such cases.
Thank you.
Thanks, sir. Thank you very much for your recent update by all the faculties about this new drug of the mucormycosis. So about the management of hyperkalemia, you already learned 1, 2, 3, 4, but still there are new drugs are available. So what are the newer drugs to treat hyperkalemia? It's my question from Dr. N.P. Singh, sir.
I think what is important when we have a case of hyperkalemia has been rightly pointed out, to see whether we require the treatment in an emergency situation where his pointers of calcium to stabilize the membrane and then to give insulin glucose holds true. But there can be a situation where potassium can be brought down in a semi-urgent situation when over 6 to 12 hours, where both these drugs can be infused slowly. Then there are conditions in which the patient has mild or moderate CKD, has increased potassium intake, or due to ACE inhibitors, ARBs, these patients have chronic hyperkalemia. Now, there the only drug which we had, apart from, of course, doing a dialysis, was sodium polysulfone, sulfonate, which had a very, very significant, we need to have given it in patients with these patients with sorbitol, so that to prevent constipation and prevent colonic ulcerations, which are very, very well-known complications. And also there are certain contraindications of giving sorbitol in certain conditions like ulcerative colitis, etc. So this drug was not very effective, and it was not very urgent also. Now we have two important drugs. In fact, I was thinking as how to pronounce it. So I thought Rajasthani way, Patiromar. So Patiromar and zirconium cyclosalate are two drugs which have come in the horizon, as rightly pointed out. I think SEKHAR also once talked about hyperkalemia management long time back, 2-3 years back in annual update. So this drug, zirconium cyclosalate, when given in doses of 10 grams 3 times a day, actually brings about the reduction in potassium within a span of 2 to 3 hours, which is pretty urgent, pretty fast. Similarly, Patiromar has been also found to be, when given in 8.4 grams repeatedly daily or over a period of 3-4 days, have been found to be excellent drugs, not only used for chronic hyperkalemia management in patients with CKD, but also have been found to be very effective in semi-urgent situation where you need to give, them in a 3 times a day modality. Unfortunately, even today, I don't know why, there are certain patients of mine who have been on zirconium, but they are all getting it from abroad. Both these drugs are not available as of now, so we rely on, as rightly pointed out, salbutamol. So salbutamol, unfortunately, does not find itself in update. We know update up to date is a drug formulary which can give you the latest. This is, I think, Indianized version which we do, but we're doing it very effectively. But these two drugs are very, very promising, not only for acute management, but also for chronic management. The side effect profile is very, very acceptable. They just cause mild constipation and they do not result in significant side effects, which was the problem with sodium polystyrene. And though they would be costly when they come, but I'm very sure Indian pharmaceutical agencies are going to master them and provide us with the cheaper versions. So these are the two drugs which are in the horizon. But if these drugs are not available, then we have no choice but to use sodium polystyrene solution in certain situations. And but then we need to understand that we need to give them with solvitol and also ensure that these patients do not and this drug is not very effective in acute situations. Many a times we have a tendency to give this drug whenever the referral comes. But please understand, in acute situation, hemodialysis or the previous drugs which have been mentioned are very, very effective in bringing down them. Simultaneously, we may start, but these two drugs, I'm very sure Dr. Sanjay will agree with me that these two drugs are so promising. But I'm very sure in 2021, by the end of 2021, we'll have them in the.
Thank you, Dr. NP Singh. There's one point. We understand that in management of hyperkalemia, beta-2 agonist salbutamol has a big role to play. But what message would you like to give to the pulmonologist who primarily not because of hyperkalemia, not because of electrolytes, because of the patient who is a respiratory distress, but most important drug is a nebulization and nebulization. And that is to beta agonist with steroids, ICC, inhalational steroids. So, and many times we have seen while treating such a patient, they develop a muscle spasm, even the cramp in the hands. So what message would you like to give at what doses they should start putting on a potassium supplements? So not to have a concurrent side effects of the beta-2 agonist as a hyperkalemia.
I think very rightly put out. Please understand that patient is one. Chapters are different. There are drugs which can cause hypokalemia, hyperkalemia. There are drugs which are effective. So we need to treat the patient and not the individual. You are very right. But as pointed out by Dr. Pandya, the dose required to produce hypokalemic effect is very high, 4 times higher than the normal dose which we give for treating bronchodilators or bronchodilation. That is one. But very rightly pointed out, I think steroids are much more culprit, which can cause alkalosis is another one which can cause hypokalemia. So a combination of all these three can produce a significant muscle weakness. And when the respiratory muscle becomes weak, these patients are again more prone to develop respiratory failure. So again, very, very clearly pointed out, if you have a patient who's got hypokalemia and these patients are on drugs, and diuretics, again, you need to first understand that we can stop or at least reduce the dose of these drugs and give potassium supplement so that ensure that patient does not go into that perpetuating state where he does not come out of the respiratory failure.
Thank you very much. So
actually, interestingly, a patient was admitted with respiratory distress. So the patient may assistant transfused, that is, he has given nebulizer, salbutamol as usual. Then he called me, sir, the patient became bad. I immediately asked what is his potassium level. Sir, I will measure immediately. The potassium was very low, 2.2. Hypokalemia sometimes will present as respiratory distress.
Absolutely.
Once the potassium is corrected with potassium chloride, the patient has become immediately all right. So we have to be careful.
Yes.
Thank you very much, sir. So back again to Dr. Sanjay Pandya. We believe and we have been informed by that not treating hypokalemia only by potassium doesn't make any sense till you do not get magnesium, because magnesium and iron that increases the potassium excretion. So Dr. Sanjay, would you like to add now something which have been observed, what you have mentioned now, that the magnesium, the role in management of hypokalemia, sir?
I think he's already
we discussed.
We discussed. Yeah. We have discussed already.
True enough.
Discussed already.
Yes.
I think we move to the next question, probably the last question that Dr. Pandya has already briefly told about this potassium phosphate and potassium chloride. But before going to this question, I just myself is asking one thing, that when we were doing PG in Jaipur and SMS, Dr. SK Parikh sir was our chief, and he used to do ECG morning, evening. ECG kiya nahi kiya, especially because that time electrolyte facilities were not available. So what is the role of ECG presently in managing or diagnosing hyperkalemia? Still we are using in day-to-day practice because in small setups where facilities are not available. Can we treat patient with on the basis of ECG, or in maintenance and repetition without doing electrolytes? Can we manage the patient with ECG findings? What's your opinion, sir?
I think both are supplementary to each other. The ECG is a very sensitive and specific marker of hyperkalemia and also probably of hypokalemia. As I had pointed out, it can easily help us in excluding, false causes of hypo and hyperkalemia. Suppose if the patient is asymptomatic and the potassium is 5.3, but ECG is normal, 5.6 ECG is normal, we can rest assured that we are dealing with pseudo hyperkalemia. Yes, if the patient has significant hyper, suppose sometimes we get a patient with potassium 8, 9, but if the patient has to have a heart block, have to have a sine wave, if the patient has such a high potassium level, you are absolutely right. In the era when we did not have these electrolytes, especially being measured in the hospital with the right technique, we were relying on ECG. But nowadays, I think most of the ICUs not only rely on serum or plasma level, but also rely on potassium level of the ABG as well, which can be easily done. So both can be done, but I would still feel that we need a facility of serum potassium in our lab, in our ICUs, in our ward, if we want to treat such electrolyte disorders.
Correlation between ECG and serum potassium level is not always a perfect.
Yeah.
Many of the patient, about 50% of the patient with a proven hyperkalemia, ECG may be normal. So ECG is an adjuvant but not a replacement of serum potassium level.
Okay, thank you, sir. So today's last question about the potassium phosphate and potassium chloride in the management of hypokalemia, and how much potassium does IV potassium phosphate contains?
See, basically,
that has already told.
Already we have discussed, but only I will highlight that most of the patient needs KCl, POTPHOS or potassium phosphate is a concentrated additive. 1 milliequivalent contains 4.4 milliequivalent. So if you have proven hypophosphatemia, like patient is in ICCU or there is refeeding syndrome, or some of the diabetic patient, diabetic ketoacidosis patient can develop hypophosphatemia. So if you have proven hypophosphatemia, then this molecule can be used very concentrated. So adequate dilution is very important. Available in 15 ml ampule, contains 66 milliequivalent of potassium.
Thank you, sir. So over to Dr. Girish MATHUR, sir, please.
Thank you, GD. So I think we had a wonderful panel discussion, which was very informative and meaningful. And all the panelists, Dr. Sanjay Pandya, Dr. N.P. Singh, and Dr. SHASHANK were at their best. Now I invite Dr. K.K. Parikh, sir, for his remarks.
Unmute,
So please unmute yourself.
Unmute kare, sir.
We had an excellent interaction. Actually, interaction is more important, but we had a masterly lecture by Sanjay Pandya and then great interaction and by all the panelists. I thank you, Dr. Pandya, for being here and sparing your valuable time for this webinar. We are really happy and we feel obliged because every time we trouble you. And I'm grateful to our chairperson, Dr. D.P. Singh, Dr. SEKHAR Chakraborty, and Dr. MUNISH Prabhakar for being here and chairing these sessions. I'm really grateful to Dr. Rajkot, Dr. N.P. Singh for being a very good, we had a very good discussion with their presence, and lot of things which comes in our mind have been cleared. Even then, I think after such a masterly lecture and such a great discussion, even many times we forget. So we have got we have recorded all the webinars when we do. And so anybody who needs it to revise, any delegate, we will be very happy, and we will give in the groups also that you can have this webinar, recorded webinar, and you can go through again and again, because every time when you see a patient, then you know that what to be done and what not to be done, and then we forget. So thank you everybody. Thank you Pradyumn Sharma, thank you Dr. Ramchandani, and thank you Dr. Girish Mathur for organizing such a wonderful CME program webinar. Thank you our chief guest Dr. YP MUNJAL, and guest of honor Dr. SHASHANK Joshi, Dr. UPADHYAY, and Dr. KAMLESH TEWARY. So I think we had a wonderful session, and we are much updated now about potassium disturbances. Now, next talk, we will trouble him again, Dr. Sanjay Pandya. We will have a next webinar on acid-base balance. So I think that is also very important, because in ICU, we every time ask for ABG. So this is very important. So Dr. Sanjay, we'll trouble you again. Sure. And it's really a pleasure to welcome you again on that webinar. So good night, everybody. Thank you so much.
Thank you.
Dr. Pungalia sahab, ab tak bhi hai. Thank you so much. Hem Shankar ji, Dr. Hem Shankar, Dr. KK Sharma. Thank you so much. Thank you, SEKHAR.
बहुत मजा आया सर.
नहीं, really, it is a wonderful.
Thank you, Dr.